In this episode, we meet Linda Murphy, Health and Social Services Coordinator at the Calder Centre, part of the Auckland City Mission. Linda has been a nurse, a librarian, an Anglican minister, and a Human Rights Commission employee. In 2003, she slipped on a wet pavement on Wesley Street and was picked up by a dishevelled, one-eyed man while suited pedestrians walked by. That moment changed the direction of the rest of her life. For more than 20 years, she has been accompanying vulnerable people through illness, crisis and death at the Calder Centre. In this episode, Linda talks about what it actually takes to accompany someone through the health system when they are frightened, traumatised and possibly cognitively affected. She talks about the corrections pipeline, the people who are housed but still cannot sleep indoors because the walls themselves are frightening, and why she does not think there is a single patient at the Calder Centre who does not suffer from PTSD, and she talks about what would actually help. More information on this episode can be found in the episode description. And don't forget to subscribe to the Char Hub podcast, wherever you get your podcasts from.
Linda, thank you so much for taking time to talk with us here today in the heart of home ground, the Auckland City Mission. Can we start by, I can ask you to tell us a little bit about yourself and what brought you into this work?
Okay, well, I born in Auckland at the very beginning of the 1950s, and I was educated in Wellington, went there when I was 7, and came back to Auckland in 1968. The Wahine storm and the Murchison earthquake drove me back. I was at Wellington Girls College and we evacuated twice that year. I thought Auckland seems a much safer place. And I haven't left Auckland since. I hadn't had anything to do with homelessness in all my life. I'd been nursing. I'd worked here in the city a lot of my life. I worked for the Human Rights Commission. I was a librarian. And then in 2003, my husband and I decided to sell our family home in Mission Bay because our boys wouldn't leave home. So we thought, right, we'll do this because they were in their 20s. So we bought an apartment in Federal Street in Hampton Court. And I was going out for a walk down Wesley Street and it was raining and I slipped. And this man picked me up and he had one eye and he looked quite dishevelled. And as it turned out, he is still here at the mission. He's now housed, but he was homeless at that time. And all these men in suits kept walking by, but this person picked me up. And then I started to sort of look around and thought, oh, it's quite a need. And I was working as a verger at St Matt's then. And the verger, as you will know, looks after the operations of the church and the weddings and at St Matt's, so it's a lot of functions. And there were a lot of the rough sleepers spent a lot of time at St Matt's. So I started washing one of the woman's clothes and feeding her. I engaged mental health services to come and assess her, and we were able to house her in a rest home, Everlaw, out of Mount Albert. And she stayed there until I got a phone call from them a week before we went into lockdown in 2020 to say that Caroline was very ill and could I come and see her. And sadly, because she was in a rest home, I wasn't able to, and she passed just before we came out of lockdown. So that was the first person I was involved in housing, and the list grew from there. I worked very closely with the mission in terms of being a volunteer and doing things in conjunction with Wolf Holt, who is, you'll know, and his team, which was a team of himself and one other social worker at the time. And that team has now expanded into 7, and that is a team I work very closely with, the outreach team, because really high-risk people are sleeping out there on the street, and we don't want deaths on the street if we can avoid it. Sadly, this last year we did have one. So.
You've played a significant role in supporting and improving the health of people you serve. Can you tell us about your work at the Calder Centre? And you've touched on palliative care and the importance of integrated healthcare.
Right. 10 years ago, 16th of February, in fact, 10 years ago, I went into the Calder Centre as a member of what was called the crisis care. So it's more like front of house as now. And Helen asked me to take on that role, but I was able to shape it as I felt the need. When I talked to the doctors and the nurses on staff at the time, and they'd been at the mission since the Calder Centre started in 2006, it was, we need help to get patients to outpatient appointments, and of course they're at Green Lane. So if you live in the city, it's a couple of buses, or you just don't go at all because you can't afford to. So I spent a lot of time taking people to appointments, and that proved to be quite important because our whānau can't speak medical language. I can't. Well, I sort of can. But if my husband needs to go, I go too, or I'm sure you'd go with your partner, because it's a scary environment. It's not friendly, but they don't really speak in a very straightforward manner. So I spent a lot of the last 10 years not actually training doctors, but asking doctors to rephrase things so that people can have a better understanding of what they're talking about or what they're being offered in terms of treatment. Because it's informed consent, but quite often they'll say yes and they have no idea what they've said they were consenting to. And I think that was the start of a really important part of that integration, but also Calder's role in making sure that patients were prepared, they had support, and these days I have 40 or plus key workers that can do that for me. So I get spread around, that part of the role gets spread around. In that integration I spend a lot of time talking with social workers on the ward because they'll ring me, I'll ring them because I know they've got my patient there or somebody I know who's unwell. So we can try and work for a really good discharge plan. Now, it doesn't always happen because there's a lot of self-discharging goes on, but we've got communications going on, and I get lots of phone calls. Do I know such and such? Yes, I do. And so we can put some good discharge plans in place and with supports. And so that's part of the integration.
Fantastic. Can you tell us a little bit, especially for people who are not familiar with the mission, not familiar with home ground, what's the nature of the service within the health service within this building, and how do people engage with it?
Right, well, Calder Health is part of the PHO. It's a GP practice. We have a GP every day, a nurse practitioner, and 3 practice nurses, 2 of which are nurse prescribers. So it's a well-equipped practice. Anybody can enrol. We have very low charge. We also have a dentistry as well, which is a huge plus. We have walk-in clinics in the morning, and they are usually very busy because people, as any medical practice, it's 3 weeks to get an appointment with a doctor. So they come to walk-ins because they need their medical certificate renewed this week. So that's the big driver for getting people in. But we don't manage to do 10-minute appointments or 15-minute appointments. That would be a luxury for us. I think they average out at 40 minutes, but 71% of our patients are high needs, which means they've got comorbidities such as diabetes, cardiovascular disease. They won't have just asthma or COPD or something like that. It's complex. They've got more than one really complex issue, which takes time to work through, and trying to make sure that they have their medication, they attend outpatient appointments, makes it usually a pretty long consult for the nurses.
You've spoken about homelessness and the impacts that has on health. Can you expand a little bit on that, please, in terms of life expectancy? And because a lot of people watching, listening, reading won't be aware of the characteristics and nature of the community that you're serving.
Okay, I've been keeping statistics of our deaths, and I went back to 1997 when we had electronic recording of our whānau. The average age of death, and I'm glad you're sitting down, is 55 years for men and 54 for wahine. It's shocking. Homelessness just shortens your life. And we have a death every fortnight. They're not always registered at Calder, but they have been in the past. But they will have a history of homelessness and association with the mission. And it's a very sobering exercise recording that data every fortnight.
I understand you've had an important role in honouring people who have passed away and that process. How do we ensure people experiencing homelessness are treated with dignity in death as well as in life?
We are so lucky that we have a wonderful relationship with Mercy Hospice at College Hill. And they have a community nurses team. I have a really close, well, sadly, a really close relationship with them because I work with them a lot. I go out with them to visit our whānau who are palliative patients. Sometimes, like death doesn't have a timetable.
Yes.
So sometimes it takes time, sometimes it's very quick. But those nurses are just wonderful, just making sure that pain is under control, they have the needs they need. And my role is to support those nurses because sometimes those environments are not that comfortable. Then when they go in, as they get closer to end of life, they will often become an inpatient. If they are homeless, we usually can get them into a rest home so that they can get the care they need. In Canada, they have a palliative nurse that goes out on the street, but I like our idea first. I think it's better, and we're lucky that we have got various rest homes. We'll take them and support them and are very tolerant of the unusual behaviours of our whānau because they do still take drugs and they still will drink alcohol because they're addicted and that's their way of life. And we have been very lucky that the rest homes have been very tolerant of that behaviour. But I try to be available, not so much myself these days, but I'm supporting key workers who death is often quite new to. It's not to me, and I support them and support the whānau, and we work together. And you just have to have lots of patience and lots of our heart and give them lots of time because it's just time that they need, and it often takes them a very long time to understand that they're dying. Even though the doctor said you're dying and you have a few months to live, it will not dawn on them really until quite close to the end. Oh, I am dying. But I've never seen any anger with that. I've just total acceptance. And that, the last one, or most recent, well, not the most recent, but one of them that comes to mind, he was only 47. So yeah.
So with you've got a very interesting mix in your life of the spiritual, being a priest, the medical, and caring for the physical realities. Obviously, there's huge diversity within the homeless community of people and culture, and you've talked a little bit about the premature ageing and death that comes alongside homelessness. If you had a magic policy wand that could change the system in some way to improve our ability to support people appropriately, and maybe even into the realms of preventing homelessness, particularly around people being discharged from hospitals and residential psychiatric and emergency departments into homelessness, is there anywhere you would wave your magic policy wand?
One thing that Dr. Richard, who used to be here, was one of our GPs, and he always hoped that one apartment in home ground would be for a transitional sort of living space for somebody just discharged from hospital or was going through chemo or any of those things where we need really eyes on that person all the time. That would be one dream, but I'd probably want a whole floor of home ground for that, 10 apartments minimum.
Yep.
And I think I'd probably fill them.
Yes.
Certainly would with the current lot I've got up at the hospital at the moment.
What would you call that? Would that be palliative care, or would it have a
No, it
different...
wouldn't be palliative. I think we could keep in with that transitional care, but it's like a hospital and home care.
Yes.
If we could have that, we've got an outreach nurse, we've got the medical centre downstairs, we've got 24/7 staff. It would be just that safety net around people. Probably not going to save a lot of lives, but it will prolong life, and it may give a better quality of life. So that would cost a huge amount. But that would be perfect.
Yeah, so that's a gap that you've identified that's not currently being well served.
Yeah.
Yeah.
Yeah, it's a real problem. It is a real problem. Because there's various options. There's things like the triple PNR, which is a protection of personal property rights. If a person is designated of not having cognition to make their own decisions, we can put a person under that and then forcibly put them into rest home. But if their cognition's fine, what do we do?
Yes. Yes. Forgive me, Linda, if I go a little political here, but there is a group of people in society characterising homelessness as a choice. I wonder if you, having seen what you've seen, lived the life you've lived, and walked the path that you have a view on that question of, would somebody, in your experience, out of all the choices they've got available to them, choose the life of a rough sleeper or a homeless person?
I'd like to quote something from a sermon I gave on social services Sunday. I reflected on my 20 years of working with the homeless, and it's not just about putting somebody in a whare and giving them the keys. If you've had a childhood of fear in your whare, you've never felt safe in a whare, and you live in a state of hyper arousal, how do you live? How do you ever live indoors? And that is what we deal with here. I don't think we'd have a patient at Calder who did not suffer from PTSD, and that comes from childhood trauma, whatever. But that's where the original trauma happens, and that is what we battle. We've got people housed and they still sleep on the street because they can't sleep indoors because it's too frightening to do that. So we've got to work at the bottom end to ever fix the top end. And I have spoken about this at many a dinner party, I can promise you. But it's something I feel very strongly about because the general population don't realise they don't have a choice. It's too scary. It's just too scary.
focusing on some success, which I think we're seeing with the integrated nature of housing and health services. What are your reflections on how well that model works? And what I'm really asking here is that sometimes in the public discourse and in media and in Parliament, the conversation around homelessness is just a conversation around houses, and it's not a conversation about health, mental health, addiction. Any reflections from you around that integrated nature of services and why it matters?
Oh, well, we can't just house because it's not going to happen. They won't stay housed because they need support to stay housed. Addiction is with someone for life. Gosh, I know plenty of addicted people in the best part of society, so it isn't just homeless people that have addiction issues, but they have addiction issues that are complicated by their trauma, and it leads to the mental health issues because we get psychosis, because we get the tainted drugs out there on the street as well. So there's nothing simple. It's always very complex. But with the Housing First model, we've got a model to work with, and I watch key workers and support these key workers do the best they can. I've got a kids harm reduction clinic here that runs once a week, but the clinician is going to come again tomorrow. So, you can get things done, but you can't do them in isolation, and you've got to work with this wider village and we do have some successes, but they are small. I will acknowledge that. And the general population do see the worst sides, the homelessness, but they actually don't. They're actually just there, and acknowledging them would be helpful, and not give them money would be good, just buy them food. But that's really what we need to do. We do need, I think it's, my responsibility to let my group of friends know, and I hope that they share that. I have a son who works, he's a musician, and he teaches jiu-jitsu, and he carries that message too. Because both my boys, my other son lives here in the city, and they know the homeless population very well because that's been part of their lives for the last 20 years. So I think it's a slow process.
Linda, the general public see the more visible aspects of homelessness in rough sleepers and at the traffic lights, but there is a huge hidden homelessness population across the country. We've heard in not just major urban centres, but also in rural communities as well. Am I right to think that similar life experiences, traumas, difficulties and health challenges exist with that group that are living in precarious? They might be sofa surfing, they just might not be literally on the streets. But are you treating and meeting people who we could call the hidden homeless?
Oh, absolutely, yes. And I've got a lot of those. Other cancer patients who aren't getting their medication, aren't attending their appointments, aren't getting their chemo. And I've got this wonderful group of oncologists who try their best to try and catch them. So I try and do the catching and connect the doctors, and they'll come to the clinic. That's what we can do. We have a surgical clinic once a month, and Mike will send me a list. I really would love to see these people, and they're the people that are falling through the cracks and not getting, and they're usually the ones in that housed but not housed. They're sleeping on sofas, they're sleeping in a car, and a lot are women.
Right.
A lot of those are women.
Yeah. And many of us struggle to take our medication at the best of times, but if you didn't have a fixed home, it must be a nightmare.
Yes. Well, how does a diabetic have their insulin when they don't have a fridge? There's some basic things. It just doesn't happen. Yeah, and it is hard to remember to take medication. I don't remember to take mine every day, I have to say, but yeah.
Now tell me, in your work within the medical practice here, you've obviously on many occasions had an interface directly with emergency departments and hospitals. How does that look and work? And are there areas we could think about more as a society in terms of supporting better outcomes?
But, well, I attend an Auckland ED meeting every month on a Wednesday. In fact, I've just had one earlier today. And we discuss high frequent visitors in the ED. They sent a list of 15 patients on Monday. 8 were ours. Okay, so that gives an idea. So I make sure that they know who the key worker is. They've got phone contact for a key worker. I'll make sure that the key worker knows what the management plan is at ED, and we go from there. But quite often, ED will ring me and we've got such and such, nothing really wrong, they just need housing. And I'll say, well, just send them down, and they'll taxi them down here, and I'll connect them up to the hub, and we might go from there. But, we don't have 10 or 20 beds waiting, so there will always be still some gap in the housing. But we do get there. Just recently, last week, we housed one of our people down in our new place in Wesley Street, who had been discharged because that was all they could find, and he had terrible heart failure. This place was stairs, which wasn't ideal, but now he's moved into Wesley Street. So we've got there. Nothing's a quick fix, and nothing is in life. But that is that's why I need those 10 beds, really. Well, why Calder Health need those 10 beds.
One of the things we're exploring is how to address, rather than the symptoms, which are expressed as trauma, homelessness, addiction, the root causes. And it seems that the current situation we have in New Zealand is the result of a number of political choices that have occurred over quite a long time, some of them compounding, and some of them the problem being that there are significant changes with changes of government and even within government. If we could agree as a nation the sort of country we want our children to live in, what are some of the big things you think we might be doing differently?
I just want to go back even further.
Yes.
I had a nana who was a solo mum, and she had to work in sharing sheds to care for my mother. I had a granny here in Ponsonby whose husband had a job through the Depression. She fed the street. So I come from a background that knew hardship, but also knew about generosity and sharing, because my nana door was always open. There would be lots of people staying there. There was never, I'd go in there and didn't know who was there, but the nana was looking after them. So there's always been people in need. We've just got an extreme after the, was it 87 government when Mr. Muldoon.
Yep.
So then we had those huge changes, and that's where we have that start of unemployment, the lack of the traditional employee for a Māori and Pacifica, and it's just changed and changed and changed. But we still have the social responsibility of looking after each other, and we are each other.
That's exactly what we're talking about. I mean, there's this great divide continuing to emerge between those who have and those who don't, and I suppose the question we're all asking is, as a community, as a population, do we care enough to do something about this and to look after our most vulnerable?
Yeah. Well, look, we got home ground, and that was donations, a huge amount from the tangata of Tamaki Makaurau, and a lot of those came from the areas that will be voting for the people that we are talking about. So I do think it can be done. I think it's just that relationship building. I mean, Helen Robinson's really good at that.
Yes.
And so is every commissioner that I've worked with, Dame Diane and Sir Chris Farrelly. They all did that. And I think it's responsibility of all of us who work here to actually carry that message and work with our own cohorts to spread that message. And I guess that does happen. I hope it happens more than possibly it does. But certainly, I think that's the only way. I think that's the best way to do it. Because otherwise, we'll just because this is a lot of colonialism stuff going on here, we need to change that message and work together and come out of it together.
So if Simeon Brown as Minister for Auckland and Christopher Luxon as Prime Minister came to your church next door when you were preaching and suggested perhaps that homelessness should be illegal and that homeless people should be forcibly moved on by the police without regard to providing them with adequate housing or support, what might your message be?
It could be quite harsh, I have to say. My reaction would be very harsh to them.
Yeah.
They're
both supposedly men of faith?
Yes, they are, aren't they? I would be very clear that you cannot do that, because we've already got huge numbers in the prison now, and what they do is they discharge them to the street. So how about fixing that one up, and then we'll have half the number on the street, and then we might have a bit more luck sorting out that one. Because, it's the justice system, corrections, that we've just got the cycle. Discharge from custody.
Into homelessness,
no benefit, sleeping on the street, grumpy, wet, and you somebody, so you're back in prison again. Excuse me, that's just ridiculous. And that's what we have a lot of.
I think they call that insanity, don't they? Doing the same thing again and again and expecting a different result. Just in awe and feeling enormous gratitude for the work that you and the people you work with do. Because a lot of people just wouldn't have a clue that this is actually happening every day, 24 hours a day, 7 days a week. And so I just want to thank you for the amazing mahi that you have done and do and the team that you work with. It's just awesome.
I'm retiring on the 20th of November. Can't even get it out, can I? But I might come back in 2027 in a slightly different role. But I suspect it'll still be in health, because I think that's where I'm meant to be.
Well, they've obviously got a real gift for it, but I love the combination of the spiritual and the physical, and just want to acknowledge your many years of service. It's just beautiful to hear you share your knowledge and experience with us, so thank you so much.
We'd like to thank Linda for taking the time to speak with us for this episode. More information on this episode can be found in the episode description. And don't forget to subscribe to the Cha Hub podcast, wherever you get your podcasts from.